Morning, everyone. Welcome to the panel on controversies in the management of parotid tumors. I'm Dave Isley from Baltimore, Maryland. I'm very honored to be co-moderator of this session along with my colleague who is visiting from New Zealand, Randall Morton. And we have 4 experts in this area who will each give brief proscribed lectures on topics that pertain to parotid tumors, and then we hope to have adequate time to discuss some cases that we've prepared to really flesh out what are the controversies in the management of these tumors. We certainly encourage audience participation, so if you have questions, please come to the microphone, and we hope to have adequate time for that. I will introduce the first 2 speakers, and then Dr. Morton will introduce the second 2. Our first speaker is Professor Heinrich Ihro from Erlangen, Germany, and he's going to discuss fine needle aspiration biopsy in frozen sections.
Ladies and gentlemen, dear David, dear Randall, thank you very much for inviting me to give a presentation dealing with fine needle aspiration biopsy in frozen section. The goal is to have a histology before coming into the theater. And you know, if you perform FNA or frozen section, you know the sensitivity, specificity, and accuracy, correct positive, correct negative, and the correctness rate. These are the results you would like to have. A correct positive in 100%, correct negative in 100%, a correctness rate of 100%. But it's really difficult to get it. Fine needle aspiration cytology. That means we perform diagnostic aspiration of cytological sample using 20 to 25 gauge needles. And you can see example, Warthin tumor, you see some erythrocytes and some cells of the Warthin tumor. Fine needle aspiration was used by cellular gland lesions for a long time, and it's widely adopted in since the 1970s. The advantages, it's safe, fast, well tolerated, and you can perform it in local anesthesia. But performing fine needle aspiration, you can make some mistakes. You can have some errors in the taking of the sample due to the cytologic material, and it's very difficult to interpret the specimen. Look in the sampling errors. You can hit the tumor, you can see A. You can beside the tumor, you can hit the cystic area in the tumor. The tumor is outside of the lump, therefore you can't hit the tumor, you can't hit the cells, or it's not possible to gain enough cells to interpret the specimen. Cellular gland neoplasms are diagnostically challenging. You have a high diversity, nearly 50 different tumors. The cytology shows low-grade nuclear morphologic features in many malignant tumors. The interpretation of FNN material is very, very difficult because you cannot have the architectural features and the extracellular and intracellular material. And this is very often important to find the right histology. And one important point, cellular gland tumors are relatively uncommon, and therefore you must have a pathologist beside you, very experienced in this kind of tumors in the head and neck area. Some examples of confusing cases. Arsenic cell carcinoma could be mistaken for benign tumors. Adenoid cystic carcinomas, often confused with monomorphic adenomas. And low-grade lymphomas, often confused with reactive nodal hyperplasia, performing FNA. Another examples, cellular pleomorphic adenomas, monomorphic adenomas, low-grade carcinomas, mucoepidermoid carcinomas, adenoid cystic carcinomas, or low-grade adenocarcinomas overlap in the nuclear features between. Here you can see some results published during the last years, till 2014, starting at the end of the 90s. Look at the red numbers. The sensitivity is between 50 to 60%, and only in very seldom studies you have a result in sensitivity of over 90%. The same with the specificity. Therefore, performing FNA is something sometimes like throwing a coin. The mean sensitivity is 75%. The maximal sensitivity is 90%, 92%. Therefore, FNA can never exclude a malignancy. The conclusion dealing with fine needle aspiration cytology. Clinically and biologically divergent tumors can look quite similar. The best practice is limited to specialized centers. And remember, in the parotid gland tumors, you have the lowest FNA accuracy rates among all head and neck sites. Therefore, you have a high false negative rate for the diagnosis of malignancy. We considered the last years how to manage these problems. And if you have big lumps in the parotid gland area, you can perform core needle biopsy using 14 to 18 gauge needles, and then you can harvest, guided by ultrasound. You can harvest specimens for frozen section, and you can perform frozen section before going in the operation theater. Looking at the results of frozen sections, you can see the sensitivity is much more higher than in FNA, between 70 to 80 to 90%, very seldom to 100%. 100% in sensitivity and specificity, I don't believe in it. Performing core needle biopsies and frozen section, especially in parotid gland tumors. Looking at the results, you have a quite high specificity, quite reliable positive results. The mean sensitivity of frozen section is higher than fine needle aspiration cytology, and the combination of FNA and frozen section give you an overall sensitivity higher than 95%. But remember, 100% is not possible to get in frozen section as well, and that's a problem in the operation theaters. You must mention it. Because in salivary gland histology, you have a high number of different malignant entities. It's very difficult to diagnose low-grade malignomas. Benign disease may be similar to malignancies. You have sometimes in pleomorphic adenomas pseudoinvasion. And lymphomas could be mistaken for poorly differentiated carcinomas. And the most important rule performing frozen section parotid gland tumors is for the pathologist: be never false positive if you are handling the facial nerve in the theater. And if you're performing frozen section during operation procedure, during surgical procedure, you must have beside you a pathologist with deep experience in salivary gland pathology. Thanks a lot for your attention.
Excellent. Professor Uro, thank you. That really sets the stage in terms of understanding the limitations, some important caveats in the use of fine needle aspiration, biopsy, and frozen section.